Good morning. My name is Makoto Mihara, director of the Mukumi Clinic, Tokyo, Japan. Mukumi means lymphedema in Japanese. We specialize in lymphedema treatment. Today, I would like to talk to you about how lymphatic ultrasound is transforming lymphedema management. I'm very much looking forward to attending the WSRM Congress in Barcelona in April 2025. This video features my presentation on lymphatic ultrasound. We perform about 380 LVS surgeries per year, with 4 to 5 anastomosis per surgery. That means we conduct roughly 1,600 lymphatic-venous anastomosis annually. For us, lymphatic ultrasound is the most critical tool in achieving surgical success. Lymphatic ultrasound transforms team dynamics, and more importantly, it transforms LVA indications by individualizing lymphatic vessels. When I first performing supramicrosurgical LVA, the incision sites were based on surgeon experience. Sometimes we couldn't find a vein, sometimes no lymphatic vessel was present. Therapists in charge of conservative treatment had a lack of trust, and surgeons expressed suspicion and doubt. We wanted to earn the trust of patients and our multidisciplinary partners by accumulating and publishing solid scientific evidence. Hard work, hard work, hard work. In 2012, we published a paper that became foundational to our work. The central theme was what causes lymphedema after cancer treatment. This photo on the left is the most important image from that study. We collected samples of collecting lymphatic vessels during LVA surgery and evaluated them histologically. We found that the vessels had significantly narrowed lumen, thickened walls, and ultimately lost their functional capacity. We categorized these pathological changes into 4 types, which we published as the NECST classification. To provide a more intuitive understanding of lymphedema, we have prepared a special CZ video focusing on collecting lymphatic vessels. When cancer treatment involves lymph node dissection or radiotherapy, lymphatic flow can be obstructed, causing intraluminal pressure in the vessel to rise abnormally, much like a balloon being overinflated. This process places significant stress on the vessel walls analogous to hypertension in arteries. Prolonged high pressure causes the vessel walls to thicken and harden, narrowing the lumen. In the process, reminiscent of arteriosclerosis, endothelial cells can seal off under such intense pressure. Allowing lymph fluid to leak into surrounding tissues, a primary driver of lymphedema. As this condition worsens, the lumen may ultimately close entirely, destroying lymphatic functionality. We call these phenomena lymphatic sclerosis. Before using lymphatic ultrasound, treatment decisions were subjective, often leading to disagreements within the team. Now, with objective lymphatic ultrasound findings, we can unify treatment strategies, and I have found that this has dramatically improved our teamwork. Let's think about psoriasis prevention from a teamwork perspective. In 2014, we conducted an international collaborative study to precisely evaluate how effective LVA is in preventing psoriasis. The most important figure in the paper is a graph in the upper left corner. It compares psoriasis incidence before and after LVA. We found that psoriatis episodes decreased by nearly 1/8 following surgery. In 2024, we conducted a randomized controlled trial comparing conservative therapy alone versus LVA plus conservative therapy. The main focus was to establish clear evidence for both approaches. We compared outcomes between the CDT-only group and the LVA plus CDT group. However, psoriasis prevention and reduction in tissue hardness was significantly better in the LVA group. There were no significant differences in limb circumference or pain. To achieve limb size reduction, combining LVA with liposuction may be necessary. However, many Japanese patients are satisfied with LVA alone. We shared this evidence within the team. This allowed us to clearly define treatment priorities, leading to more efficient and harmonious clinical care. We would like to introduce our 2016 paper on lymphatic ultrasound. The topic was Can ultrasound identify the best site for LVA? In LVA surgery, abnormally dilated lymphatic vessels are the prime targets for anastomosis. This study showed that ultrasound is highly effective for preoperative site selection for LVA, as illustrated in the bottom left figure. We also demonstrated that NECST classification can be applied by ultrasound. The key point in ultrasound is the ability to differentiate veins from lymphatic vessels. To make this easier, we summarized 5 key points for differentiation and named the method DCAPS. We published this in 2021. I won't go into detail today, but it's a simple and useful tool. I encourage you all to check it out. Even in advanced lymphedema, if we can locate dilated lymphatic vessels using ultrasound, we can still achieve excellent treatment outcomes with LVA alone. We've published nearly 20 papers on lymphatic ultrasound so far. They are the result of our hard work, blood, sweat, and tears. Please check PubMed when you have time. Today, I only shared a small part of our work. Lymphatic ultrasound has turned tension in the treatment team into harmony. It has become a shared language for all staff involved. Here is our take-home message. Please remember 2 key concepts. NECST classification to assess the stage of lymphatic sclerosis, and DCAPS, a simple method for differentiating lymphatic vessels from veins. These 2 tools will truly advance your lymphedema care. Thank you very much for your attention. Thank you very much for watching. I hope this presentation helped you see the potential of lymphatic ultrasound in transforming both patient care and team collaboration. In April 2025, we published the first Japanese language textbook on lymphatic ultrasound, along with educational videos. After this lecture, you can watch the video introducing the Japanese version of the textbook right here on YouTube. The English and Chinese versions of the textbook introduction videos are scheduled for release in August 2025. I hope you will watch them when they become available. Let's continue advancing patient care and teamwork together. Thank you again for your time and attention.
この本では、リンパ浮腫治療のスペシャリストである三原誠医師と原久子医師が、下肢静脈エコーを日々実践している超音波検査技師や、リンパ浮腫治療に携わる形成外科医、セラピストに向けて、実践的なリンパ管エコー活用術を分かりやすく解説しています。多彩な 3D アニメーション映像や臨床ケースを豊富に盛り込み、明日からの診療で役立つ知識が身につく内容となっていますので、ぜひご一読ください。また、この本を保管するため、リンパ管エコー検査を詳細に解説した11個の動画を作成しました。ここでは、 その一部をご紹介します。
リンパ管は全身の組織から老廃物を含む組織液を回収し、リンパ液として心臓に送ります。リンパ液の流れが障害されると、組織内にリンパ液が貯留してリンパ浮腫が生じます。正常な四肢の集合リンパ管は直径 0.2mm 程度の透明な脈管でノーマルタイプと呼んでいます。リンパ節覚醒後などでリンパ液が鬱滞すると、リンパ管は内圧が上昇して拡張型エクタシスタイプになります。リンパ管内圧が上昇した状態が続くと、やがてリンパ管壁の平滑筋層が飛行し、内腔が狭くなる収縮型コントラクションタイプになります。また、リンパ管内皮細胞が損傷し、リンパ液が周囲の組織へ漏出することで、リンパ浮腫が発症します。最終的に、リンパ管壁が著しく飛行した硬化型スケローシスタイプになります。こうしたリンパ管変性の過程をそれぞれの頭文字を取って、NECST分類と呼んでいます。正常なリンパ管は高エコーの白い二重線の間に低エコーの黒い内腔がわずかに見え、イコールマークまたはハンバーガーサインと呼ばれます。拡張型では低エコーの内腔が拡張し、収縮型では高エコーのリンパ管壁が厚く目立ち、硬化型では内腔がなくなって飛行したリンパ管壁のみが観察されます。動脈は拍動しているので区別しやすい一方、静脈とリンパ管を見分けるのは困難です。そこでリンパ管の5つの特徴を把握しておくことが重要になります。これらの特徴は頭文字を取って D カップスと呼んでいます。D はドプラー。リンパ管はドプラモードで色がつかないという特徴です。静脈には赤血球などの反射体が流れているため、ドプラモードで色がつく一方、リンパ管を流れるリンパ液には赤血球などの大きな反射体が含まれていないため、現在の超音波技術では色がつきません。C はクロッシング。リンパ管は近傍の静脈に合流せず素通りするという特徴です。静脈は筋位に向かうほど細い脈管が合流して太くなっていきますが、集合リンパ管は細いまま走行します。U はアンコラプシブル。リンパ浮腫のリンパ管は静脈より圧縮されにくいという特徴です。リンパ浮腫の監視では、リンパ管内圧が上昇しているため、プローブで圧迫した際に静脈よりもリンパ管が潰れにくくなります。P はパラレル。複数のリンパ管が合流せずに並走することがあるという特徴です。複数の静脈が合流せず横並びで長距離を走行することは非常に稀ですが、リンパ管ではしばしば見られます。そして S はスーパーフィシャルファシア。リンパ管は線筋膜直下にあるという特徴です。線筋膜は脂肪層の中央部にある高エコー体として観察されます。リンパ管エコー検査で観察される集合リンパ管は線筋膜のすぐ下にあり、線筋膜と水平に走行します。リンパ管エコー検査では、これらのリンパ管の5つの特徴、D カップスを確認しながらプローブを操作することで、静脈との鑑別が容易になります。
その他、 エコー検査のセッティングやプローブの比較、ケーススタディなど、リンパ管エコー検査に必要な知識を詰め込みました。本編をぜひご覧ください。